Get started. First of all, I want to welcome everybody this morning to season 2, episode 2 of EmPowHER. Special thanks to VLU that is dedicated to global venous education. Lowell Kabnick, Anil Hingorani, and Victor Kanata are my dear friends and colleagues who are on the executive board of VLU. Today, I've got with me my dear friend, Ruth Bush, who is my co-conspirator in this process. Also, together with Rebeca Reachi and Lina Vargas, who are our wonderful moderators and our colleague. And I will let them introduce to you our panel of speakers who we are so grateful and honored to have. So I don't want to hold up any more time, Ruth.
Happy Saturday to everyone. Good morning or good afternoon. Thanks, Kathleen. So I'm very excited for episode 2, round 2 of EmPowHER, sponsored by the Vein and Lymphatic University, Chancellor Kabnick and President Kanata, as well as the sponsors, BD and Boston Scientific. We're excited about today's panel on ultrasound. I do want to remind everyone of, I can't share my screen, but of the American Venous Forum, of which I am this year's president. The meeting is in February of 2025 in Atlanta, Georgia. And also about the webinar following this webinar, sponsored by Dr. Rashad Bashara from Cairo, the Egypt and African Venous and Lymphatic Society's Advanced Phlebology webinar. That will start at 11 o'clock Eastern Time, 6 p.m. Cairo time. And then my last shout out is to the Journal of Vascular Surgery, Venous and Lymphatics. I'm editor-in-chief of that journal. Love to see your work submitted. JVSVL is a global journal. It is now open access, which means that there is no subscription needed to be able to access any of the articles. So with that, thank you, and I'm thrilled to be part of this. Thank you, Dr. Ozsvath.
Thank you, Ruth. And next is up will be our wonderful moderators, Lina and Rebeca. So go ahead, take over.
Thank you very much, Kathleen. Well, I'm going to present, first of all, Aleksandra Jaworucka Kaczorowska. I guess I trained it a lot to say it. I did it well. Thank you. She's a dear friend. I have 2 dear friends here. This one is Nora Sánchez Nicolat from Mexico and Aleksandra from Poland. I learned a lot of them about venous ultrasound in different parts of the body. So I invite them because I want them to show us some tips and tricks about it. So I'm very happy that Aleksandra and Nora is with us, and I'm going to present both of them. Nora Sánchez Nicolat is a vascular surgeon here in Mexico. She's very famous in venous ultrasound of legs. She made the fast technique that she's going to show us, the fast technique for venous ultrasound for aesthetics. And she works in Mexico City. She's a board certificate vascular surgeon, and she works in a hospital. Well, she works at private and public hospitals here in Mexico. And Aleksandra is a dear friend too, and she's working in the, it's a kind of difficult to pronounce, but it's Jaworucka Surgery Center in the Center of Radiology and Aesthetic Medicine in Warsaw. I hope I did it well. But she graduated to the medical school in Karachi, in Poznań, Poland in 2004. And she obtained the title of Doctor of Medical Science in 2010 and the title of Specialist in Gynecology and Obstetrician in 2012. And the title of Specialist in General Surgery in 2017. and she graduated from the School of Aesthetic Medicine in Warsaw in 2019. So, well, she's very known in our, in our venous things because she do a lot of pelvic veins. So, I don't know if we are going to start with Aleksandra or we are going to start with Nora. What do you think, Lina?
Either way, I think, Aleksandra, do you want to go first?
I can go first. Yeah, sure.
Okay.
Okay. Thank you
Perfect.
very much for the
Welcome.
invitation. It's really a pleasure to be here with you. Thank you very much. It's really a kind presentation of myself. So thank you very much, Rabbi. I love you very much. So I will try to share my screen, but I cannot share. So I think Victor should allow me to, because I have.
Right.
I am trying, but there is written that that you have to allow me to share the screen. Still nothing. Still the same. I still have the information that you do not allow anyone to connect, to share the screen, any of the participants.
I believe Rebeca Reachi has control.
So Rebecca, maybe you have to. Oh yes, I can do it now. Thank you. I don't know who, but
Great job.
I didn't do anything, but anyway.
Okay. Anyhow, it's working. So ladies and gentlemen, the topic of my lecture will be ultrasound investigation of pelvic escape points. I have nothing to disclose. We know that pelvic venous disorders may have a different clinical presentation, and one of them are varicose veins of pelvic origin. So we can have a vulvar varicose veins, as you can see here. We can have atypical varicose veins, so the varicose veins which are located in the atypical areas, like you can see on this photo. And we can also have a typical saphenous truncal incompetency because of the connections with the great saphenous vein or anterior accessory saphenous vein or small saphenous vein. We have to remember that most of these patients who are coming with varicose veins of pelvic origin do not have pelvic symptoms. Generally, less than 10% of these patients have a pelvic symptoms. So generally, they are usually coming because of this varicose veins, not because of the chronic pelvic pain. When we talk about the treatment strategy and diagnostic strategy, I will show you the flow chart, which is from recently published European guidelines, so ESVS 2022 clinical practice guidelines. We can find there, then whenever we have a patient with pelvic venous disorders and the varicose veins of pelvic origin which are suspected, besides of the full legs duplex ultrasonography of the lower extremity, we should also perform transperineal duplex ultrasonography to evaluate, to look for the pelvic escape points, so the connection between the pelvis. How I perform it: whenever I perform the duplex ultrasonography to evaluate pelvic veins, I do it in the under Trendelenburg position, just to do not overdiagnose like compression syndromes, for example. Also, when I perform a transvaginal or transperineal duplex ultrasonography, it's also usually in this position. So what pelvic escape points we are looking for when we are performing duplex ultrasonography? We are looking for this three pudendal pelvic escape points. So there is a clitoral, intermediate labial, and perineal posterior pelvic escape points. They are the most common. You can see the best on the publications. They are found in 70% of patients with varicose veins of pelvic origin. The second one very often is inguinal pelvic escape points. It's found in almost 21% of patients with the varicose veins of pelvic origin. There are two gluteal pelvic escape points, inferior and superior gluteal, and an obturator pelvic escape points, which is the rare one. I will start from the anatomy because it is the most important. So this is a pudendal region, and this is the clitoral pelvic escape point. So this is a plexus, which is a connection between superficial and deep dorsal vein of the clitoris, and which is a tributary of internal pudendal vein. And there is also this intermediate labial pelvic escape point. So here you can see it's connected with the vestibular bulb vein. So the second name of this vein is intermediate labial vein. We have also this perineal point. So here is the perineal vein. Another name of this vein is posterior labial vein. And now I am more often seeing also patients with rectal vein. It's not described in the literature, this pelvic point, but I can also, I have like 3 or 4 patients with the veins coming from this region also. So maybe this pelvic escape points will appear soon also in the publications. So how to perform duplex ultrasonography? This is the position which the patient is usually lying when I assess this. Here you can see in the middle, this is a clitoris, and on the both sides of the clitoris, you can see this clitoral pelvic escape point. I will show you some examples. This is also the clitoris, you can see it, and then the clitoral, this vein, so this is a superficial dorsal vein of clitoris. It's connected with the external pudendal vein, and usually it goes to the saphenofemoral junction and cause, like you can see on this photo, this varicose veins on thigh. This is another example. There will be a video. You can see the clitoris, and this is this plexus, clitoral plexus. So the connection between this superficial and deep pudendal veins. Here you can see the superficial pudendal vein, external pudendal vein, and which you can see when you follow these varicose veins, you can see that it goes to this saphenofemoral junction and cause this atypical varicose veins on leg. Another patient, also we can see the clitoris and this clitoral plexus, so the clitoral point, and you also follow this vein, and here you can see this external pudendal vein. And we always have to follow where the varicose veins are going. So we can see the varicose veins clusters and the mons pubis, and it also causes varicose veins on leg. And another case similar on the other side, so it looks similarly. So you have to localize clitoris, and then on the both sides of the clitoris, you are localizing the clitoral pelvic escape points, and very often it is connected with the external pudendal vein and cause the varicose veins on leg. So generally, when we have patients with the varicose veins on leg, we should go up and check if it's not related with the external pudendal vein, and if it is not connected with the clitoral pelvic escape points. Like here, you can see that the patient was after 2 operations. She had a great saphenous vein stripping, and then anterior accessory saphenous vein stripping. You can see 2 scars, but after 6 months, the varicose veins appear once more, and because she had incompetent clitoral pelvic escape points connected with the external pudendal vein, which caused this varicosities. Let's go to the next pelvic escape point. So it is intermediate labial pelvic escape points. I usually start it from with the probe localized transversally, and below this clitoris, you can see that there is a vulva, and here you can see the vein. It's not normal vein. So this is the vestibular bulb vein. So it is located usually in front of the vulva or on the side of the vulva. Then you have to go lower. So in between the vulva and the anus, so rectum, there's usually this perineal posterior pelvic escape points, as you can see on this photo here. Of course, it's not, but I will just want to show you how this examination I performed. And then I changed the probe longitudinally, and here you can see the rectum and then the vulva. And generally in this position, usually we have this perineal posterior pelvic escape points, and then we go up. And here usually is this intermediate labial pelvic escape points. And now I will show you some examples. Here is the patients with the bilateral varicose veins of pelvic origin. Here you can see the clitoris. And when we go lower, you can see this huge intermediate labial pelvic escape points. So it's a vestibular bulb vein, which are responsible for this varicose veins, which you can see on the photo. And here you can see that this pelvic escape points are really big. Another, it is in longitudinal position of the probe. So in front of the vulva, you can see this pelvic escape points. And another case, it's very interesting. Wait a minute, I have to show it. This is very often misunderstood, that it may be clitoral pelvic escape points, but you can see that it's below. So this is intermediate labial pelvic escape points, which gives also tributaries to the upper part and cause this varicose veins on on the labia majora. And here also another patient with this pelvic intermediate labial pelvic escape point, so located in front of the labia. And another case also, we always have to follow this pelvic escape point, so you can see when you follow it that it is related with the varicose veins on the leg and also on the thigh. And here I show you that the patient doesn't have this perineal posterior pelvic escape point, so only this intermediate labial pelvic escape point was responsible for this varicose veins, which you can see here. And here you can see this perineal posterior pelvic escape points, which cause this varicosities. So here you can see the rectum, and you can see also the vulva, and in between of this, and this is the perineal vein, so posterior labial vein in other nomenclature. Here the patient had 2 pelvic escape points, which was responsible for these varicose veins. And when we follow this pelvic escape points, you can see that there are the results, they cause these varicosities. And another patient, this is very interesting patient with huge varicose veins on the labia majora, as you can see on the photo. So here is in the medial labial pelvic escape points in front of the vulva. And when we follow it, you can see that this is responsible for this huge varicosities on the labia majora. But when you check the perineal posterior pelvic escape points, you can see that she also has this pelvic escape points. You can see the rectum, you can see the vulva, and we also follow this pelvic escape points. And you can see that this patient, that these varicose veins on the labia majora were caused by these 2 pelvic escape points, so intermediate labial and perineal posterior. Let's go to another pelvic escape point. So we have inguinal pelvic escape points. It is found in 20% of patients. It is a round ligament vein incompetency, which is it's located in the inguinal canal. Here you can see how it looks like. It's really easy to find the reflux, localize the reflux in this vein. And I will show you some cases. So the patient with such varicose veins, and which was related with the inguinal pelvic escape point. So here you can see where this vein is coming to abdomen, and then when you follow it, looks usually like a spongy tissue. And it's very often also connected with this external pudendal vein at the mons pubis, as you can see here. And then it goes, in this case, to when we follow it to saphenofemoral junction and cause this atypical varicose veins on leg. Another patient, also this inguinal pelvic escape point. So here it goes to abdomen. We follow it, and we can also check the reflux, if there is a reflux in this vein. And you can see that there is a huge reflux in this inguinal point. And also another patient with such varicosities. You can see there is a huge inguinal pelvic escape points. Here it goes to abdomen, a huge spongy tissue related with the external pudendal vein. You can see that there is a big reflux in this vein and cause these varicose veins on leg. And another patient, very often the inguinal pelvic escape points can be sometimes small. Like in this case, you can see that it's not as huge pelvic escape points, but it also may cause a varicose veins on leg. So generally, when we suspect that it may be of pelvic origin, we really have to look for it, because see that it is connected with this veins and supplies this varicose veins. And even that small pelvic escape points may have a really reflux, and it needs to be closed whenever we have a patient with varicose veins of pelvic origin to achieve good results. And this is very interesting case, patients with bilateral varicose veins on both thigh and also on both legs. And you can see here there is a clitoris, so she had a huge clitoral pelvic escape points. So I followed it. And here you can see that the patient has also inguinal pelvic escape points. So these 2 pelvic escape points were responsible for these varicose veins on leg. So here you could see the inguinal pelvic escape points. Here we go to the clitoris, so a huge varicose veins clusters at the mons pubis. And you can see that when we follow it, they go to saphenofemoral junction and cause this varicose veins on leg. And on the other side, it was similarly. So you can see the clitoris, this plexus, clitoral plexus, so the connection between deep and superficial. and we follow it. We go here is external pudendal vein. When we go further, you can see that in this case, you can see here that it is an inguinal, a spongy tissue, so inguinal pelvic escape points. It goes to the abdomen, and it is the reason of these varicose veins in that patient. Let's go to another pelvic escape point. So the next one is the gluteal pelvic escape points. You know that we have both. Generally, when we would like to localize it, firstly, we have to localize the piriformis muscle because one goes above and the other one goes below the piriformis muscle. And here you can see how it looks at the duplex ultrasonography. I usually perform this one in standing position. And this is an interesting case because the patients had two. Here you can see the superior gluteal pelvic escape points, but when we go lower, you can see that the patients had also huge inferior gluteal pelvic escape points, which cause this varicosities. And the last one is obturator pelvic escape points, which comes from the obturator canal. It's the rarely one, but also we have to check it whenever we have a patient with at least one pelvic escape points. We always have to check it. Generally, when we are doing duplex ultrasonography, we have to follow the varicose veins where it goes to find the source of the reflux, and it allows you to achieve good results of such treatment. So even in case of such huge varicose veins, which you can see here, in that case, I usually perform sclerotherapy of this pelvic escape points, and we can really achieve good results. But generally, the most important is the proper diagnostic before the treatment. So whenever we have a varicose veins of pelvic origins, superficial duplex ultrasound, specific duplex ultrasound assessment of pelvic escape points is recommended, and accurate evaluation of all pelvic escape points is essential for good treatment results. Thank you very much.
Thank you, Aleksandra.
Thank you.
Well, I guess we are going to have some questions, but we are going to do it at the end of the second talk. Did you agree?
Yeah, sure, of course.
Okay, let me introduce now Dr. Nora Sánchez Nicolat. I really thank Nora because today is the Mexican Congress, and she's not in her house, she's out in Puebla. And Nora, do you hear us?
Yes, perfect. I'm here.
Okay. Would you make an introduction when I put your video?
Yes, of course. Thank you for the invitation, Rebecca. I am going to share my experience using the venous ultrasound in the FAST technique for patients in phlebistotic problems in the early stage of the venous disease. And thank you very much. I am going to share my video. Rebecca is presented. Thank you very much.
Victor, I cannot share my the video. Could you allow us, please? Victor.
You may have to have Alex
Yes,
unshare.
I have it.
Okay, good. Great job.
Let me see. Okay, I'm going to share. Did you hear?
No.
No?
Yes, everything is okay, but there is no sound.
Okay, let me see why. I'm gonna stop it and let me see why. I guess it's because
I am disconnected.
okay.
While Rebeca is working on this, Alex, that was an incredible talk. This is Kathleen Ozsvath. I just wanted to say that maybe when it comes time for questions, I would love to hear from you how you hold the needle, because sometimes it's so difficult with the mucosa and the skin being
My name is Nora
so
Sánchez.
flexible. I'll stop talking, but I'd love for you to address that.
Yeah, sure. Maybe I can answer because I don't. I think the Rebbe is not. Yeah, generally it's not easy to puncture this area. I usually use longer needles and just try to puncture deeper because when you puncture very superficial the vein, very often the foams go to the varicose veins and do not go to the pelvic escape point. So I use like needles like 4-centimeter needle. And just do it longitudinally and see the whole course of the vein when it goes to the varicose veins. And before the treatment, I usually use an anesthetic ointment 30 minutes before the treatment, 30 to 45 minutes before the treatment. So it's not that painful for the patient. So I think it's also very important. So
thank you for that. Yes.
Yeah.
Rebeca, are you all set?
Yes, yes. I'm trying to share it. Let me try again.
I think that Victor needs to allow you once more, because when I am trying to share.
There you go.
You hear? Okay, and now I'm going to share this. Okay. Perfect.
There is any sound?
No?
No. You need to
Hear it? Hello? Did you see it and hear it or not?
We can see it, but we cannot hear it.
Okay, Nora, can you share it?
Okay.
Please, because I put all the sound and no, nothing happens.
Okay. Could you close your screen to share mine?
Yes.
So while the ladies are working on that, yeah, Alex, I learned that the hard way. I also prescribe the lidocaine cream because it's terribly painful. And I have a really good assistant who can kind of hold the skin in place, which also helps.
Yeah.
How are you doing, ladies? Yeah. Go ahead.
I generally do not. Sometimes, with the patients had a huge varicose veins, it's much easier when someone is helping you and hold it so that it's not be so movable. Yeah, that's also a nice tip and trick to do it.
Thank you.
I'm ready.
Perfect.
Can you see my screen?
Yes.
Yes.
Hi, my name is Nora Sánchez. I'm a vascular surgeon from Mexico City. Today, I am going to talk about the use of fast technique in phlegosthetics. Doppler ultrasound is the diagnostic method of choice to confirm the presence of chronic venous disease. It shows the cause and patterns of venous reflux. The level of evidence is 1A. We know that the anatomical and hemodynamic characteristics in chronic venous disease vary between patients. With this technique, we can perform a fast and effective study in patients with telangiectasias and reticular veins. We know that in this kind of patient, there is any deep or severe reflux. Just we need to know if this patient has some axial reflux. The ultrasound provides hemodynamic, morphological, and functional data, and it allows for the study of anatomical variants. With high sensitivity and specificity, in the FAST technique, it's important to analyze the size and parency. The ultrasound has some advantages. It's easy to perform, non-invasive, consistent, and shows reflux, obstruction, and anatomical location of the diseased vein. It's important to place the patient in a standing position in order to distend the vein. We use the Valsalva maneuver in the femoral popliteal vein and in the saphenofemoral and saphenopopliteal junction. The office should have a warm temperature and be comfortable for the patient. We need a linear multi-frequency transducer between 6 to 13 megahertz. We can see the patient in my office. The equipment adjustment are the following. We need to adjust the color, low frequency, and PRF. We need to adjust the color box for the size of the vein. The steps for the fast technique are the following. We start at the femoral vein and the saphenofemoral junction bilateral. After that, we study the small saphenous vein and popliteal veins. We continue with the gray saphenous vein above and below the knee bilateral. We don't use the Doppler wave. The use of color shows us if the vein is competent or incompetent. For this, we use the Valsalva maneuver or leg compression. If the vein is competent, the color disappears. On the other hand, if the vein is incompetent, the color changes to red. In the fast technique, it's important to measure the veins. This allows us to know the positive predictive value more than 90% when the vein at the saphenofemoral junction is greater than 8 millimeters, 6 millimeters above the knee, and 4 millimeters below the knee. And we have the negative predictive value more than 80%. When we have 5 millimeters at the saphenofemoral junction, 3 millimeters above the knee, and 2.5 millimeters below the knee. The vein measurements must be taken at 3 centimeters at the saphenofemoral junction. After that, in the gray saphenous vein above and below the knee, and the small saphenous veins. We use the transversal view to measure the veins. The first two steps start with the patient in a standing position. We using the Valsalva maneuver, we study the femoral vein and the saphenofemoral junction. Then we can see a normal saphenofemoral junction, and in this image, we can see the reflux at the saphenofemoral junction. In the step 3 and 4, we study the small saphenous vein in double image. We perform the study of competence for the popliteal vein in longitudinal view and distal compression. In the step 7 and 8, we study the saphenous vein above the knee in transverse view. We can see the image that when we study the gray saphenous vein above the knee, we can see some branches at the saphenofemoral vein. In the step 7 and 8, we study the competence in longitudinal view using the distal compression. This is done bilaterally. We can see the reflux at the saphenofemoral vein. In the step 8 and 9, we study the saphenous vein below the knee in transversal and longitudinal view with color and leg compression. We take its measurements to be sure its size. If a dilatation is present, its measurement should also be taken. We can see the video analyzing the saphenous vein below the knee. Talking about the perforating vein, they are not important during this easy stage of chronic venous disease. They only play an important role in more advanced stages and recurrence of the disease. This technique was validated by Dr. Ignacio Garcia Lugo. He demonstrated that this simplified technique allows us to perform short studies in early stage of chronic venous disease. Using this method, the analysis goes from 24 to 13 minutes with a high sensitivity and specificity. The fast technique has a high sensitivity and specificity in this kind of patient. Finally, the take-home message are the following. The fast technique is an adequate and quick evaluation which allows us to find axial reflux in early stage of the chronic venous disease. With it, we can go without the use of Doppler wave, which in turn saves time, allow for the treatment to start sooner. Conclusions. The FAST technique is a quick ultrasound exam with accurate diagnosis. Early stage of the chronic venous disease must be studied and classified properly. The disease should not be underestimated. Thank you very much.
Thank you, Nora.
You're welcome.
Lina, we have some questions.
Can you hear me?
Yes.
I was trying to, I had to register to be able to go on. I'm not sure that I'm in here as a moderator, but the important thing is that you guys can hear me. So Nora and Alex, that was both incredible talks, very, very important, I think, in today's world and the patients that we are trying to help on our practices. So Nora,
Lina, can you try to open your video, please?
Let's see if it's working now, because it wasn't working. It's on.
My video?
Mine.
No, it's Lina's video, but we cannot.
Mine is on, but yeah, I don't know why it's not working. I'll try to keep working on it, but just for the sake of time. So Nora, obviously, you know, we are all located in different parts of the world, and so this approach may be different, but so you're seeing someone for cosmetic reasons, for spider veins, telangiectasias, maybe small reticular veins, and so when you want to do this fast ultrasound, are you doing this on everyone? Is this a routine part of like someone who's coming just for a cosmetic concern? Is this something that you have the patient, you know, pay for it? Is that included in your payment? And then also kind of as a second part of the question, what happens when you do find something that maybe is more, you know, more medical, some more significant insufficiency, like what's your process in your clinic?
Yes, I perform this technique for all my patients in my private practice, because for me it's important to show my patient if they have some axial reflux. After that, I perform all my phlebistotic treatments, and I make sure that there is any axial reflux, I can give better results, because for that I perform this technique in my patient who comes to my office for an aesthetic problem.
Yeah, I think I think that's very important. I think it does make a difference sometimes when we're trying to make sure that our patients get the result they want, right? And being able to identify important, but I think like most places, and I would love to hear everyone else's experience. Like in my case, it's something that I would love to do, but just I guess at least my setup, which is kind of half insurance based for medical treatments and half, you know, aesthetics. It's just hard to like separate those and have a streamlined way of making sure that even all aesthetics patients get a fast ultrasound. Do you charge them for that, or is that included in your treatment?
Yes, the patient must pay for the ultrasound, because I perform before the treatment, and I give to a report including the reticular ultrasound, and I give a complete cartografia for them. Because of that, the patient must pay for that.
So then if that patient, if you do find something that's more significant, what happens then? What's your protocol then? Do they get a formal ultrasound, and does that go through insurance, or how does that work?
All my patients are in my private practice.
Okay.
And there is almost all of them, there is any insurance. They pay by themselves.
Just pay out of pocket. There's no insurance involved. Yeah, that's really, really interesting. Thank you.
Yeah, because you know,
Yeah. Oh, sorry.
Don't worry, Lina. Besides that, I guess how much time do you spend in the fast technique, Nora?
Really, I perform a fast technique when I want to start with the transdermal laser or with the sclerotherapy. I know I take maybe 10 minutes to perform all the ultrasound. And when I finish and when my patient go out to my office, I give by QR code all the complete ultrasound for them.
Perfect. I had a question for Alex. So do you find yourself treating most of the lesions like the ones you presented on your presentation today, like transdermally, locally in the perineal area, or do you ever do, you know, intravascular treatments from let's say, you know, ovarian veins or through the internal iliac vein? Do you
So
ever do that,
everything-
or is it essentially
Yeah.
all transdermal and external treatment?
Everything depends what the patient's about the patient's symptoms. If the patient is coming only because of the varicose veins of pelvic origin without pelvic pain, I usually start from the bottom-up treatment. Of course, when the patient comes and she has the varicose veins and the pelvic symptoms, and she would like to get rid of pelvic symptoms, so I start the procedure from embolization. But generally, most of these patients do not have pelvic symptoms. So generally, they do not even know very often that the varicose veins are coming from this origin. And they are very often, you know, like sometimes in 60-year-old patients with the recurrent varicose veins, and I'm doing, oh, we have a varicose veins of pelvic origin. She was really surprised. So I am generally against of, and also the guidelines say that whenever we have a patient with the varicose veins of pelvic origin without pelvic symptoms, we should do the bottom-up treatment. It should be considered as a first-line treatment and do not do embolization, because the study has shown that even if we perform the embolization, very often this patients also needs the bottom-up treatment for these varicose veins. So I am not keen of doing pelvic vein embolization in such patients. Of course, when you have the recurrency, fast recurrency after your treatment, or when the veins do not close, but it happens very rarely, you know, we can perform it from above, but it's not a first-line treatment in my case.
Yeah, I think, and that's the reason why I asked the question. I think that's very important because I do feel that some people may feel inclined to just think that you gotta treat internally the origin, and a lot of times that's not the case. You know, I do feel, and that's kind of the discussions that I have with my patients, as far as, you know, you're not burning any bridges by starting from the bottom. It's definitely a safer, you know, very effective, I think. But I do tell them we may have to come back, just like with lower extremity vein treatments, we may have to come back maybe a second time, third time, but it's something that's definitely easier than going to a cath lab and doing a more invasive procedure that may not necessarily be warranted. So
yeah, and also, you know, there was a study, and they were they checked if the pelvic vein embolism, it was in Kasten Miller study, and he checked if there is a it has an impact on the recurrency of the varicose vein. So it doesn't. So even though they have performed pelvic vein embolization, 54% of patients had a recurrent varicose vein. So it's also do not, because people sometimes think, oh, I have to do a pelvic vein embolization because it will prevent the recurrences. No, but it's not true. So so that's why, you know, there are so many. You are all doing the pelvic vein embolization. You know that there are the plexuses there. There are lots of varicose veins. So very often the patient is coming after a year, and she has another varicose vein from another ovarian vein, or for tributaries of internal iliac vein. And, you know, I had a patients who had like 5 times embolization. They had 2 varicose ovarian veins treated, but the varicose veins on leg do not disappear. So they had another embolization, and, you know, she had many calls, sclerotherapy in that area, but the varicose veins did not disappear. And so I think it's like really over treatment of patients in many cases. That's why bottom-up treatment, I should be the first-line treatment.
thank you. Kathleen, were you wanting to share something?
Yeah, well, first of all, both of you, incredible talks. You know, I completely agree, Alex, that, you know, you got to treat what's basically what the patient is coming for. I also wanted to make a comment on Nora's talk. It's very interesting in the United States, and certainly in my area and in my practice, I treat mostly patients who are symptomatic. So the nice thing about this fast ultrasound is that it could also be considered to be used for screenings. So, like, I don't know how many of you all are involved in like varicose vein screenings out in the community, but because it's a quick and easy test, it's a very simple and quick way to determine if somebody's has issues with venous disease and then should be recommended to go see a venous specialist. But congratulations, both of you, on incredible talks.
Kathleen, by the way, I perform all venous ultrasound to all my patients. The problem here in Mexico, like Nora can see it, I work only private, and I don't charge because I don't give to them like Nora, I don't give to them the ultrasound. I do it very quick, so like a screening only. But it's amazing the number of people who has some venous, some valvular insufficiency, and they don't know, and they come only for aesthetics. And when you check it, and you find that they have some venous insufficiency, so it's for me it's good to have a record for the patients, and then see it later to see how are they going. Some of them, of course, they are not for surgery, but some of them has to be a severe venous insufficiency that they don't know because they don't have a lot of varicose veins outside. So on the superficial, they don't have a lot of problems, but they have some symptomatic issues. So for me, it's fine to have like I learned about Nora, the fast technique is very easy, and you don't have to spend a lot of time.
Yes, you don't have to spend a lot of time, but you need to have a lot of experience to do it, because I told my fellows, I prefer really fast, but I'm sure that my patient that don't have any axial reflux. And for that, you need to be fast, but you need to be accurate with your ultrasound too.
Nora, I have another question for you. So what is the role of ultrasound for managing complications? So things like matting and hyperpigmentation. Do you use ultrasound to help you navigate those situations?
Yes, because I like to use the high frequency ultrasound to see reticular veins. Maybe if I perform an sclerotherapy, maybe there is any small vein below that reticular or the telangiectasia. And with this kind of transducer, I find the right vein, and maybe that one of the cause that the patient has that kind of problem. But I'm sure when my patient had some complication, I perform the ultrasound, and my patient be sure that I am making the right thing for them.
Yeah, I think that's important for those of you out there doing, any vein treatment, aesthetic or medical, having that matting that we all dread. We know a lot of times that is due to potentially a patent afferent reticular vein. And so ultrasound for sure is, key. And like you were saying, that high frequency can really, really help you identify those smaller ones to be able to target them and be able to help with that matting for sure. I also use it, obviously, a lot of times when we're doing what I call the puncture aspiration, or you have a patient who has a little bit of trapped blood. A lot of times you can just do that without the ultrasound, just by feeling it. But it's nice sometimes to be able to use the ultrasound to really guide that drainage of that trapped blood in those cases as well. So definitely a big role for ultrasound in after you've done treatment and as you're monitoring your patients following treatment.
Yes, the ultrasound helps too with the complication to puncture the vein after you have some thrombosis after sclerotherapy. And I like to perform by using the ultrasound with the high frequency transducer.
Aleksandra, I have a question for you. Look, look, sometimes we are not so accustomed to do the sclerotherapy and to check the patients with the ultrasound. which ones were you to say that you always do? Like I always performance this, and this, like the simple way to do it. And besides that, like Kathleen said, is sometimes is a difficult part to treat, to check, because some of our patients, I live in Mexico, and some of the patients, even that they are coming with me because I'm a woman, and they are very, very sensitive about the question. So what do you think? We should have to go with a gynecologist, or the gynecologist has to check it and then send it to us? Or what do you think?
Generally, it's not easy because gynecologists usually do not know totally what to do with these varicose veins. So that's a huge problem. I think the cooperation is really great. So I think, I know it's much easier for women to perform this duplex ultrasonography and even to talk about this. Very often, patients have a problem because they are coming with the varicose veins on the leg, and very often do not say that they have varicose veins on the labia. And they do not sometimes connect, that it may be related. But I think the most important is to like the good atmosphere, talk to the patient. When you see the varicose veins are coming from this area, you should just tell the patient that. Probably for me as a gynecologist as well, it's much easier to do it. But I really would recommend everyone to talk to the patient that we have to check it, and we do it. For men, it's much easier. It will be much better to work with the woman as well in an office. So if you have a nurse who is working with you at the beginning, it will be really better because maybe the men are with embarrassed, and the woman who is a patient also may be embarrassed. So maybe it will be a good idea to cooperate with a woman at the beginning, at least, just to patient feel comfortable, and the doctor also feel comfortable. So I think it's the most important.
Yes, I think it's very important to spread the word, because there is a bunch of women who has this kind of varicose veins, and they don't have any answer. And,
Yes.
and they go to the gynecologist, and like you said, most of them, they don't know how to do it. They sometimes they perform cesarean because they don't want to deliver the baby because they have some varicose veins on the vulva, and they want to operate the girl. And I said, okay, but sometimes we have the answer to these things. So I guess maybe we can have some talks with gynecologists to spread the word that we can treat
Yes,
this
but I
time.
think the most important is also the vascular surgeons or phlebologists do this, because very often, I have a lot of patients who are coming from other phlebological offices, usually from men, because they don't want to check it. Someone needs to treat these patients. You have to be somehow you have to change your thinking, because now everything has changed. The aesthetic area part of our life is going up, and many patients are taking care about their aesthetic also in that area. So I think such treatment is very important. And I think that such webinars are also very important, just to spread it and the information how to do it, that we have to do it. Some people needs finally start doing it because these patients need help. That's why I think it is very important. And gynecologists won't treat it. They should. Generally, I have a good cooperation with gynecologists. They are sending me patients. So I think they also should be involved in such webinars, just to get the information that such treatment can be performed, because very often they even do not know that we can do anything with that varicose veins. So this is also important, I think.
Alex, there is a question on the chat. It says, I'm just going to read it. It says, the probe that Alex showed is the one I use for labial varicosities. Some use the hockey-shaped probe. What are your thoughts?
Once more?
It says that some people or some practitioners use the hockey-shaped probe.
Yes, but the hockey, I don't know if it goes really deep, so it's very superficial, I think. So generally, I don't know. I don't have an experience with that hockey shaped probe, but maybe I don't know. I don't know. Maybe Kathleen is using. Kathleen, do you have any experience with the hockey?
I'm the one that put that question there. I just got a hockey shaped probe. I use the one that you use. For me, it's not comfortable to use it. I'm not, and you're right. It's not deep enough. But I know that Kathy Gibson uses it. So I was wondering if you used, which one you use.
Yeah, no, I don't use hockey. I use normal and goes deeper, so you can localize everything, the whole rectum, vulva, where the varicose veins are going. And it's really good when you do the sclerotherapy, just to have a deeper, the probe with a deeper penetration, because you know how much foam you should inject. Because if I use a needle which is connected with a I don't know how to say it in English, but it's like a butterfly but with longer needle. So whenever I see that the foam do not fulfill all the varicose veins, we can add another syringe of foam. So generally in that area you need more foam that it's recommended by the guidelines. So I usually use more. Usually 10 ml is not enough. So when you have you need to have a good penetration of the probe just to see when the foam is going and if it's enough or not enough, because we have to remember that the redo procedures in that area are quite difficult to puncture the varicose veins again after a month. You have to wait longer just to do some of them disappear and then it's good.
I completely agree. I use a micropuncture needle and then I have that connected to extension tubing, a 3-way stopcock, and then 2 syringes.
Alexandra, what's your sclerosant of choice?
Usually for pelvic escape points, I usually use a strong one. I use 3% HSDS foam. For superficially lying varicose veins, so on the vulva and on legs, for example, I use usually 1% HSDS foam.
Gotcha. And then do you try to do anything as far as quote unquote compression in that area? So I definitely encourage my patients to get compression garments, as I'm a total believer in compression, but I definitely want to hear your thoughts or what you do.
I usually have it in my office, so they can buy it in my office. I use baby belly band. I really like this because it's also good for inguinal pelvic escape points, which is difficult to compress when they have like varicose veins, which you could see on the photos with my patients. So it is a wrap which goes over the belly or over the pelvis, and then it has 2 wraps which goes from that wrap to from the front to the bottom. So you can put the wrap on, for example, on the inguinal point, and they can adjust the pressure. Or if they have varicose veins of the labia majora, they can adjust the pressure for the varicose veins just to squeeze them. So it's really, really nice. You can buy it on Amazon. It's not that expensive. I generally have all size in my office, and when patient is coming, I just give them to them.
Do you ever, understanding that sometimes it's because these varicosities can be quite large and the volume can be quite large, and understanding that, the principle of emptying these complexes and decreasing the diameter of these veins, sometimes helps as far as like being able to use lower doses of medication or greater contact of the foam, like greater displacement. Do you ever try to do reverse trend or things like that to try to, get the most out of your medication when you're injecting these big complexes, or not really?
No, I sometimes, when I start pelvic escape points, I usually do it in Trendelenburg position because it's really easier to puncture it. When I do superficially lying varicose veins, I usually do it in normally lying position. And we know that we can use sclerotherapy for even very big veins. They did it on legs and they close really easily. So it's not a huge problem. The vein will close. You can see, when you follow the varicose veins, you know that the vein is closed because it's shrink, it's white. You cannot see the volume of the vein. Yeah. So generally, I don't have any problems even with really huge varicose veins. The problem may be after the treatment, because you have to tell the patient that it can be palpable for even 2 months. For legs, I usually do needle thrombectomy. For this area, I do not do it. I tell the patients that it will disappear, and they see that after a month it's smaller. After 2 months, it's sometimes not visible at all. It's not visible, it's palpable at all. So this is the only thing you should tell the patients, that it may be they can feel it after the treatment for some time.
Right.
I have a question before we are done, because it's almost time. But first of all, I want to thank Dr. Nora for the amazing talk. And I want to ask her if she, I know that she has a very special ultrasound, but I guess, could you give us, like for normal people like me, that we have to do something with not a special probe, it's like no hockey stick or something, Nora? We can perform the fast technique with the ultrasound, normal ultrasound?
Yes, Rebecca, you don't need to have a special ultrasound and a special transducer. You need to have a linear transducer between 6 to 13 megahertz, and that's all, because you don't need to ask for Valsalva maneuver and leg compression or take the measures, and you don't need to spend a lot of time. You need to have a perfect and huge ultrasound, just like that, because you have your right things the thing that you are seeing or you are looking for in your patient. That's all. You don't need a special ultrasound or a special traducer to perform the fast technique. To the special meaning in the fast technique, that you need to find an axial reflux for treat before your patient, after you treat all the aesthetic problem. Right, and for that you don't need a special maneuvers and a special transducer and a special ultrasound. Just like that, the measures, Valsalva and leg compression, and that's all.
Perfectly, thank you very much. Let me see, Kathleen.
There was a comment. It says, I have a question to the next aesthetic session. What about cloruro de lapidio? I have no idea what that is.
Okay, cloruro de lapidio is very well known in Colombia. We don't have it here in Mexico. That's a problem. Yeah, you're from Colombia. Come on.
Ouch.
Yes, it's very well known in Colombia, but we don't have it here in Mexico. We have it here in Mexico. By the way, we have different sclerosants, but here in Mexico, the only one who has the government allowed is etoxilerol. That it's
okay, yeah. Mm-hmm.
Laucramol, yeah.
Got it.
Yeah, but we have in Latin America there is a bunch of even glucose, but here in Mexico is not allowed to. Sometimes we do it, but it's not allowed by the law.
Yeah, it's just so interesting to see how there's so many different things, depending on where we are, and this is what I love about this community, is just being able to share. I mean, obviously we have what we have depending on, where we are, but that doesn't mean that there's no other things that may be better, and just learning from everyone is very, it's just amazing. I absolutely love that. So
yes, and besides that, let me tell you something. Maybe we have 1 hour now, but we have to stop it. But I'm so happy that you were with us to share. Thank you, Lina, for sharing me with this moderator. For example, thank you, Aleksandra. Thank you, Nora, for sharing some of your knowledge. I know that you are very good in the things that you know. And thank you for sharing with us a little piece of knowledge. And besides that, I know that some of the people has any doubt, they can contact you. We are going to follow with these webinars, because we know that the experience that they can give us, it's very important for all of us. And like Aleksandra said, sometimes we have to know that other people can show us and can talk to us and show us how to do the things. And we can, in our own world and small world, we can talk with other people to spread the world and to take care of our patients, because somebody has to do it. And I guess it's better if we can do it together and we can share our experience together. That's why the VLU, I think the VLU, that they gave us this space to share with us and to share with all of us this kind of talks. Thank you, Victor. Thank you, Anil. Thank you, of course, Lowell. Thank you, Catherine. Thank you, Ruth. Thank you, everybody.
Great
Kathleen,
job,
This will be
everyone. See you
sharing-
next time.
Yeah, the link will be shared through VLU on multiple channels. So definitely stay tuned, because we're going to keep going and keep sharing and educating. So I'm looking forward to seeing everyone on the next one.
Thank you. Everyone have a great day.
thank you. See you next time.